Now moving on to mandibular reconstruction, and I put this towards a functional rehabilitation, which then ties in to Haitam's discussion that we were having. So I like Simon Sinek's book on Start With Why. So why do we need to do this? Well, it's all about a patient. It's all about the quality of life of our patient and not so much the quantity of life for the patient. And I'll use this to highlight. This is a gentleman that was treated by one of my mentors prior to me joining the institution. He was young, 60s, obviously with a neglected tumor. He underwent resection. He had a successful composite resection. He had a mandibular plate put on and a pectoralis flap, but this is how he looked. He had his mandible was not reconstructed. He didn't have any chin or lip support. The flap was short. He didn't have any oral cavity. His tongue was hypertrophy secondary to continued trauma, and he was pretty miserable. Yes, he had a successful cancer surgery. He had radiation. He was alive, but he was suicidal. He didn't want to live. He had no quality of life. He couldn't go out. He couldn't talk. He couldn't do, as you can see, he is trach dependent. So he, in essence, was a social cripple. So I think if you take a step back when you talk about mandibular reconstruction, as with anything, any site, you have to decide what are you missing. And then you see from that question, am I missing just the mucosa, or am I missing a little bit of bone, or both? Am I missing through and through? Then you can then decide, okay, well, how am I going to tackle this, and how am I going to reconstruct these patients? We also know that there is a correlation between the difficulty of the reconstruction and the number of subunits. The higher the subunit number, the more difficult that reconstruction is going to be, and the inverse is going to be with regards to function and aesthetics. So as the number of subunits goes, the less, the more impact you're going to have in terms of overall aesthetics and the functional potentially. This patient presented to me is a young man, 65 years old. He had radiotherapy and then subsequently developed osteoarthritis necrosis. But when you look at him, on this panoramic radiograph, you can see that the disease extensively goes from one side all the way to the other side. We planned for him a resection, which is virtual guided. And, you see here we have the guiding, the cutting guides. We do the resection, so we take pretty much almost the entire mandible. There's no soft tissue component for him. So all we have to do in this case is just simply reconstruct the mandible. We do that with the fibula and a small skin paddle. And this is him afterwards. So angle to angle resection deals with that problem. And you can see based on his facial appearance that he's much happier. He has a complete reconstruction that was just functional. And most people will not be able to tell that he has this type of reconstruction. So you can deliver something that is predictable for these patients. This gentleman, on the other hand, is 65, pretty much same thing. So he went to his surgeon, who was going to do the resection and mandibular reconstruction for his osteoarthritis necrosis. However, during that surgery, he took some sample biopsy and saw that the patient had recurrent disease. And then so he referred them to me with this X-fix for re-resection and then immediate reconstruction at the same time. Now, compared to the other one, he is not only missing his mandible, but he's also missing a significant soft tissue. So soft tissue from the floor of the mouth, and that extends from one angle to the other. So his reconstruction is going to have to incorporate some soft tissue component in addition to that bone. So you can see here, and for him, his reconstruction is, as you can see here, we're a little bit deficit in terms of soft tissue on the left side. I certainly could have brought a little bit more muscle to kind of bulk him up a little bit. But overall, he no longer has the X-fix, and he's able to carry out, his normal social, can go out and eat and function with family and so on. And so for him, that is adequate. This gentleman is, again, a 47-year-old, but with a much bigger problem than the other two. If you look at in terms of his disease, it's pretty extensive, coming almost towards the skin, destroying the mandible and the floor of the mouth. And then so by the time we finish the resection, he has bilateral neck dissection, significant amount of his tongue, floor of the mouth, mandible, again, from angle to angle is taken out. And then so components that you have to reconstruct for him, all of those things. And using a chimeric fibula, we're able to tackle that, reconstructing his mandible again, reconstructing his floor of the mouth and a bit of the tongue. And you can see here on table and post-operative that the mandible has been reconstructed. But more important, when you look at him, this is him. You can see the flap both on the tongue as well as the mandible. His facial form is somewhat symmetrical. And even though he has something that prior to, in the olden days, he would have been the social cripple, much like the gentleman that I showed at the beginning. With this, with one single flap, we're able to address all of those component areas and reconstruct them accordingly. Now, some of the cases, you have the need for compartment resection. I believe I showed this gentleman before, but if you disarticulate the mandible, so in this case, you have a condyle that is missing as well. You have to think about how you're going to reconstruct that condyle. Can you do that with a free tissue transfer? And yes, this is, again, using a fibula subcutaneous flap. We are able to do the mandibular reconstruction, including the condyle, as well as the soft tissue component. And you can see here, he has pretty good facial symmetry, very good mouth opening without deviation here. And he's able to be reconstructed again immediately, addressing his primary, which is the oncologic reason, but also the reconstructive needs. This gentleman is different. I had operated on him many, many years ago. He had, similar to the previous patient, he went back to his country because he came from Venezuela for me to operate on him. He went back, had radiation therapy, and decided to have some dental implants, which he did. About 10 years later, he was not doing such good care of his implant and then developed osteorative necrosis. He was treated in Venezuela and then went to Colombia and was treated, and then had a series of events that were not ideal. And then so he then was referred back to me with this complete loss of soft tissue, lip incompetence, X-fix. He had lost all of the tissue on his left neck, had lost the bone. So now we had to take him back and readdress all of these things. So we recreated that defect, went to the contralateral neck in order to expose that, and then doing the fibula. Initially, this is the patient on table. So we've addressed, we're going to do a stage reconstruction where we've done the fibula, subcutaneous fibula. We've done the skin panel on the outside for the deficient lip, the skin panel inside to address the intraoral component. This is him early on, but he knows that this is going to be a stage reconstruction because there's lots of issues happening still. Now we take him back and we do a second stage where we do a lip revision, we do a flap debulking, and we do a contouring of his menton. And then this is him post, so that even though that he has a color mismatch, but we're able to get him from what you saw there before, where even when you look in his eyes, there's loss of sort of that vitality in the eye, and you compare them to what he looks now, he's getting back. He's back in his business, he's back with his family and enjoying life again. So you can deliver these functional reconstruction even in some of these challenging patients. I think you just have to have a good communication with them in terms of how you're going to stage it and what are you going to do in order to do that. Those cases that I showed were just with one flap. Now you can do composite reconstruction, whether you do it stage 2 flaps. In this case, a gentleman with a recurrent disease, he had been treated with surgery and radiation elsewhere, but now he failed. and then he needs a salvage therapy. So this is his resection. You can see here now he has mandible that is gone, his lip is gone, his chin and the facial skin also need to be reconstructed. So if you do that now, for him, he's no longer needs to be radiated because this is salvage and he's already radiated. So we have the luxury of time because we no longer have to be worried about that 6-week interval. So I do stage 1 is the fibula osteocutaneous flap. I do a skin paddle and the FHL for intraoral floor mouth reconstruction. This is him a few months later, a couple of months later. Now everything is stable. I take him back to surgery, and then I'll do a second stage where I do the lip reconstruction with the radial and the palmaris, and then I'll put this on top. And then this is him now after second stage. There you can see that he has, albeit in terms of vertical deficiency, but he has reconstruction of his mandible and his lip, starting from this to this in a 2-stage reconstruction. So he's not trach dependent, he's not peg dependent. He can go out and eat, albeit not the same as you and I, but he nonetheless can still do social eating and able to take the adequate nutrition requirements. You can also do composite reconstruction with a chimeric flap where you have patients such as these. This 71-year-old with a neglected malignancy, pretty extensive. When you can see that's the whole lower lip, chin, neck, floor of the mouth, buccal mucosa. So when we plan for her resection, is a pretty extensive. I like to take these measurements prior to so that I can get a good idea as to what I need to reconstruct. And this is post-resection. And you can see that the defect is pretty significant. It includes upper lip, buccal mucosa on the left in its entirety, the skin, some of the buccal mucosa on the right, the entire floor of the mouth, the mandible, the chin, the lower lip, and so on. This is the resection. And then when you look in terms of what is specific that we need to tackle, you can see the list here from 1 through 5. And then so for her, I go as a chimeric flap and a scapular system. In addition to that, I also take the latissimus. So we are able to take all of this construct from the back and able to do it in a 1-stage, 1 chimeric flap, and you can do all of those things. This is her post and prior to getting radiotherapy or in the middle of radiotherapy. So we've gone from that to that with 1 large chimeric flap. You can also do it in terms of stage, as you can see here. This is a young man, 36-year-old, with an aggressive tumor that's coming through the skin, necessitating a pretty large resection through and through, as well as mandible. For him, those deficit skin, buccal mucosa, and mandible. And I opted to tackle him, as you can see here, in with 2 different flaps. One is the fibula osteocutaneous flap that allows us to do the mandible, the condyle, and the floor of the mouth as well as buccal mucosa. And then for the overlying skin, we do an anterolateral tie. The combination as such is able to reconstruct him. He still needs some fat grafting in order to kind of compensate for some of those areas, but overall, he's doing pretty well. This gentleman depicts a different story altogether. This is a high ballistic injury with a significant component of tissues that are missing. If you see here, in terms of the middle one, you can see that there's loss of everything in the midface and the mandible. So in order to think about reconstructing this patient, it will be quite challenging. The other thing, you want to do it all at one setting. Well, you don't have to do it in one setting. I chose to do everything in one setting. And then for him, initially after the debridement, putting some of these bones together in the NOE region, and then doing a 3 free tissue transfer, one setting, right fibula for the maxilla, floor of the nose and palate, left fibula for the mandible and the floor of the mouth, and then anterolateral tie for the chin and neck, altogether, we're able to get him from what he presented to this, where you have bony reconstruction of both the mandible as well as the midface. And you can see here again, from a segmental view, and then this is him from one to the other. Now, he still needs some revision, so he still needs the lip, upper lip and contouring, the bulking, and so on. But this is him. Obviously, he's no longer trach dependent. He's lost some significant weight. You can see bilateral temporal hollowing, but he needs some fat grafting around the infraorbital region. He needs some the nose reconstructed, and he also needs revision for his NOE. But he's able to take things by mouth. He's able to breathe and speak without much problems. So if you compare those malignancy with the ones patients that have benign disease, they're a quite different story altogether, because these patients expect to have a pretty normal outcome, even to the same degree that they had prior to. And so I'll highlight a couple of examples. This is a 75-year-old with an ameloblastoma. And then we do planning. We do the resection of the ameloblastoma here, and you can see the fibula with the patient-specific implant, deliver everything here, and then this is him post. You can see his facial form is established. That's the reconstruction there. His opening is normal. The only thing that he has is that cervical incision. Same thing with this gentleman. Again, very similar in terms of the reconstruction, the anastomosis, facial form reestablished, and so on. Now, you can minimize the evidence of the incision by making a resection transorally, as in this patient. So we do a combination of facelift incision or parotidectomy incision in her, and then do the anastomosis from that perspective. And that way we minimize the facial incision. We do the reconstruction, as you can see here, but the only thing that you can notice is the one behind the ear, that incision. And then this is her. We can do, again, transoral resection. As you can see here, this is with a DCIA. The incision is slightly smaller in the infraorbital, infra-ear area. This is the DCIA in place, the dental implants. And again, you can see that rather than having the transcervical incision, a very small incision. But you can hide this even more. This is a young lady who's a nurse in the Bahamas. She came to me for resection of an ameloblastoma, and I made a small, very small incision, as you can see, inferior to the tragus and to the lobule. We carry out the resection, and this is the closure there. But when you look at her, even from a segmental perspective, you see that there's no evidence really of any facial incision, with the exception of the one by the ear. We maintain her facial form, even though she has a hemimandibular defect that was reconstructed with a fibula. I think her facial form is acceptable, and she can go on and get dental implants and is fully rehabilitated with that one single. We published this approach. But the movement nowadays is to do the whole construct at one go, whether this is referred to as Jaw in a Day, that was published by Dr. Hirsch's group from New York. This was our initial patient many years ago, had a myxoma. I resected it. And then you can see here now placement of dental implants, and then bringing it towards the oral cavity. At that time, again, this was our first patient. We had all sorts of issues with doing these composite curing in the operating room to be able to deliver this prosthesis. And this is her on table, this is her afterwards, and this is her later. The benefit is that you wake up and you have teeth and the reconstruction, and with a very small incision. We improved upon that. This is another patient with a benign disease in the mandible requiring resection. We do the planning with a virtual planning and the placement of dental implants and a patient-specific plate. As you can see here, this is delivered to us. We then take it to the operating room where we do the resection. We place the dental implants. I should say that this is done by a colleague of mine. I don't do the dental implants. This was done by Dr. Salman. So he places the dental implants in the prosthesis. Again, you can see here, this is on the leg. And then we then bring the whole construct and we insert that. And then this is closure. This is the patient afterwards. This is only a few weeks after the surgery. You can see that the facial form is normal, but more important that she has a prosthesis that is a one go at the time of surgery. Now we can certainly minimize the incision in the face. This is a young lady again with a 19 with a juvenile aggressive ossified fibroma that had failed several treatment. So a transoral resection, patient-specific plate, dental implants as you saw before. And then now we're able to use just simply a trocar incision for that condyle resection. We do again the same as you saw before, the whole construct. We put it on the leg, we bring it up to the head and neck. And this is her with little swelling on the left side, but the prosthesis in place and dentures in place. The last one I think I show you is this gentleman with a myxoma again. He's works at the hospital. This is the planning, again, patient-specific implants placement, and now we get this construct. But more importantly, this is what allows you to do the delivery, because you can see the height is done. So the teeth are in place. We get this in the operating room. And then now with a very small incision, we can do the transoral resection, where we do the tumor resection, we do the flap, we raise the flap, we do the implants, and then we can check for the occlusion on the leg, that the prosthesis is going to be adequate and it's going to be in good position. And then we can then transfer this to the head and neck from the leg on, and then implant this on the patient, put the fibula, do the anastomosis. And this is patient post. This is early on, not the breast dental hygiene, but you can see that his facial form is normal. And all you can see is the small little incision there that we use to access the blood vessels for anastomosis. So overall, I think for these patients, we're able to deliver a more predictable and more functional reconstruction simply because we're not having to worry much about the radiotherapy and the effects of radiotherapy post-op. And again, we published that. So a little bit faster, but I think in the sake of time, this is just kind of showing you some of our approach in terms of mandibular reconstruction in a predictable fashion. So with that, I'll take any questions again.